This is a review lecture on voice disorders created by Brianna Romero, Cassandra Carrasco, and Yuridia Mendoza. All information presented in this lecture was obtained from the textbook Foundations of Communication Sciences and Disorders by Dr. Paul T. Fogle. Chapter 27, Anatomy and Physiology of the Respiratory and Phonatory Systems. Before we discuss voice disorders, we will review the normal anatomy and physiology of the larynx, which is the organ of phonation. The larynx is positioned superior to the trachea and below the root of the tongue. It is composed of many different cartilaginous structures, including the cricoid cartilage, the thyroid cartilage, two arytenoid cartilages, and the epiglottis. The vocal folds are also a very important structure within the larynx. They run from the posterior midpoint of the thyroid cartilage and attach to the arytenoid cartilages, forming the shape of an upside-down V, as shown in the picture. The biological function of the vocal folds is to block the trachea and prevent any type of material, such as food or liquid, from entering the lungs. However, their overlaid function is to produce voice. The vocal folds are composed of mucous membranes, and the vocal ligament is located within the membrane. The area between the two vocal folds is called the glottis. In order to produce voice, the vocal folds move from an abducted position into an adducted one. As we exhale while the vocal folds are adducted, the air from our lungs flows up into the trachea and creates subglottic air pressure at the level of the closed vocal folds. This air pressure causes the vocal folds to separate. Negative air pressure is then created between the vocal folds. This negative air pressure, along with the elasticity of the vocal folds, causes them to close again. This cycle is repeated over and over again as we speak. Now that we have reviewed the basic process of vocalization, we will discuss how this vibratory cycle affects three aspects of voice: the pitch, the loudness, and the vocal quality. Pitch is a psychological correlate of frequency. The pitch and fundamental frequency of a person's voice depends on the number of complete vibratory cycles per second that the vocal folds perform. One vibratory cycle of the vocal folds is defined as every time the vocal folds open, close, open. Frequency is measured in hertz. Every one vibratory cycle is equal to 1 hertz. So for example, if a person's vocal folds vibrated 100 times in 1 second, that person's fundamental frequency would be 100 hertz. The smaller the fundamental frequency, the lesser the amount of times the vocal folds vibrate within a second, and the lower the pitch. The higher the fundamental frequency, the greater the amount of times the vocal folds vibrate, and the higher the pitch. The pitch of a person's voice can be altered by changing the tension, length, or mass of the vocal folds. Creating higher tension in the vocal folds causes the pitch to increase, as does lengthening the vocal folds and decreasing the mass of the vocal folds. By decreasing the tension in the vocal folds, shortening the length, and increasing the mass, the pitch will become lower. Loudness is the psychological correlate of the intensity of the vocal fold vibrations. Intensity and loudness are determined by the amount of force used to create a vibratory cycle and the amount of air that is released from under the vocal folds during that cycle. Intensity is measured in decibels. The higher the decibel amount, the louder the voice is perceived as being. The intensity and loudness of a person's voice can be altered by changing subglottic air pressure and the tension of the vocal folds. By increasing the subglottic air pressure and the tension of the vocal folds, the intensity and loudness would be increased. Intensity and loudness can be decreased by decreasing the subglottic air pressure and the tension of the vocal folds. Because voice quality is highly subjective, it is difficult to describe how a normal quality voice should sound like. The quality of a person's voice is affected by adequate vocal folds closure, efficient timing of closure, and the amount of muscle activity within the folds. Chapter 28, Voice Disorders in Children and Adults. Now let's discuss what happens when the normal process of vocal production is disrupted. Voice disorders are said to occur when the pitch, loudness, or voice quality are outside the normal range that is expected of the person's age and gender. They can be caused by either vocal abuse or misuse. Vocal abuse behaviors damage the vocal folds or their laryngeal and pharyngeal muscles and tissues. Some examples of such behaviors include screaming or yelling. Vocal misuse behaviors have a negative effect on the vocal folds and other laryngeal structures if they occur for a long period of time. Examples of such behaviors include cheering or singing outside of one's range. Voice disorders can be categorized into four main categories: functional, neurological, organic, and psychological. Functional disorders are caused by the inappropriate use of vocal mechanisms. Neurological voice disorders are caused by the inappropriate muscle control and innervation of the muscles of the respiratory and phonatory systems. Organic voice disorders occur because of a physical abnormality of the laryngeal mechanism. Psychological voice disorders occur because of an individual's psychological response, such as in cases where the laryngeal mechanism has incurred some sort of trauma and the person becomes afraid of using the mechanism for voice production. An individual's voice disorder may not fit perfectly into one of these categories. It is often the case that while a voice disorder may be classified primarily as one of the four categories, there may be components to the disorder that could be classified in one of the other categories. For example, vocal nodules may be classified as an organic voice disorder, but they occurred because the individual was screaming, which could be classified as a functional component to the disorder. Now let's review some functional voice disorders. As mentioned before, functional voice disorders occur because of faulty use of the vocal mechanism. Faulty use can be classified as either hyperfunctional or hypofunctional. Hyperfunctional faulty use occurs when an individual uses too much tension or force in the laryngeal mechanism. Hypofunctional faulty use occurs when an individual uses an inadequate amount of tension in the laryngeal mechanism. Laryngitis occurs because of hyperfunctional faulty use of the vocal mechanism. It is created by mild to severe dysphonia, lowered vocal pitch, occasional breaks in phonation, and vocal hoarseness. Laryngitis is caused by an inflammation of the vocal fold mucus and is either an acute or chronic disorder. Acute laryngitis is associated with upper respiratory viruses and bacterial or viral infections. Treatment for this type of acute laryngitis includes hydration, antibiotics if prescribed, and rest. When acute laryngitis occurs in children, their subglottic airway may become inflamed and constricted, causing the development of croup. Acute laryngitis can also be caused by abusive behaviors, in which case the laryngitis would be referred to as traumatic functional acute laryngitis. When an individual engages in abusive vocal behaviors, the vocal folds are slammed together with an excess amount of force. The vocal folds then become swollen and an increased amount of blood is sent to them. Traumatic laryngitis is usually treated by having the individual stop the abusive behavior and rest their voice. In some cases, acute laryngitis may develop into chronic laryngitis if the voice is not rested and the abusive behavior is not stopped. Chronic laryngitis is diagnosed if the laryngitis has been present for more than 10 days. Treatment depends on the cause. The individual should meet with and be examined by an otolaryngologist and receive therapy from a speech-language pathologist to try to stop any abusive vocal behaviors.
The most common benign lesions of the vocal folds that occur in both children and adults are vocal nodules. Normally, they are bilateral and transpire at the junction of the anterior 1/3 and middle 1/3 of the folds. They are caused by constant vocal abuse such as yelling, making hard glottal attacks, excessive throat clearing, and coughing. Vocal nodules cause the voice to sound hoarse, breathy, and strained. The severity of the voice quality depends on the size of the nodules. Just like vocal nodules, vocal polyps are benign vocal fold lesions that occur at the same location and have many of the same vocal behaviors. Although vocal polyps are typically unilateral, there is no definitive distinction that can be made between vocal nodules and vocal polyps. Although when taken a biopsy, polyps tend to be bigger than 0.3 centimeters, and nodules tend to be smaller than 0.3 centimeters. They are often precipitated by a single hyperfunctional event, such as traumatic laryngitis. When adding vocal abuse and misuse, there is an increase in irritation, which will result in polypoid thickening. Functional dysphonia is a voice disorder that has no organic, physical, or neurological cause, but is heard in patients with extreme tension in both the laryngeal and supralaryngeal regions. It may be hyperfunctional or hypofunctional. If it is hyperfunctional, the voice quality is high-pitched, tense, and hoarse. Hypofunctional vocal folds produce a low-pitched, breathy voice. Since there is no medical or surgical treatment for functional dysphonia, the speech-language pathologist works to improve intensity, pitch, and quality. Clients with functional dysphonia may benefit from psychological support from the clinician. Functional aphonia is a hyperfunctional voice disorder in which the person speaks mostly with a whisper, although they are able to use a normal voice when laughing, coughing, clearing the throat, and humming. There is no structural or neurological cause of the aphonia. Most of the causes have some psychological foundation, where psychological stressors or conflicts may contribute to the loss of voice. These clients respond well to voice therapy, where the speech-language pathologist helps them find their voice. Falsetto is a high-pitched, breathy voice produced by the vibration of the anterior one-third of the vocal folds, with the posterior two-thirds being held tightly adducted. That little or no posterior vibration occurs. Falsetto typically occurs in adolescents, but is mostly heard in adolescent males. There are many social disadvantages, and voice therapy focuses on lowering the client's pitch to produce a more natural male voice. Voice disorders related to organic etiologies include papillomas, contact ulcers, blunt, penetrating, and inhalation traumas, and cancer. Papillomas are soft, wart-like, benign growths on the vocal folds of children that have a viral origin. They occur from ages 4 up to puberty. Papillomas must be surgically removed as they can obstruct the airway and become life-threatening. The voice quality in children with papillomas produce breathiness and harshness, resulting in chronic severe hoarseness. Speech-language pathologists help children develop their best voices and teach them vocal hygiene techniques. Contact ulcers are small, benign vocal fold ulcerations that typically develop at the juncture of the middle one-third and posterior one-third of the length of the folds. They can result from one or more of the following causes: persistent and excessive vocal hyperfunction, gastroesophageal reflux that invades the laryngeal and pharyngeal regions, and intubation for surgery. The vocal quality in these individuals is hoarse and fatigued. While usually no surgical removal is needed, the medical management of gastric reflux is essential. Clients with contact ulcers respond well to voice therapy, where the goal of the speech-language pathologist is to eliminate vocal abuse and misuse and teach voice conversation techniques. Numerous traumatic injuries can affect the larynx and compromise the airway, needing emergency medical or surgical treatment. Some of the injuries can result from car accidents, where the larynx is compressed or crushed by the steering wheel, attempted strangulation, and penetrating neck wounds, such as from bullets. Voice therapy helps clients achieve a more functional voice within the limits of their altered larynges. Laryngeal cancer requires medical and surgical management, as well as a speech-language pathologist to help the client with their hoarse vocal quality. Voice disorders related to neurological etiologies include hypoadduction, hyperadduction, vocal fold paresis and paralysis, and spasmodic dysphonia. Hypoadduction is defined as difficulty making the vocal folds close strongly enough or long enough for normal phonation. Myasthenia gravis, Parkinsonism, and peripheral nerve damage are some of the neurological disorders with hypoadduction problems. The voice quality for clients with hypoadduction is weak and breathy, where the voice often deteriorates throughout the day. Hyperadduction is difficulty with vocal folds closing too tightly or for too long. The voice quality sounds tense and strained and tends to fatigue. Vocal fold paresis and paralysis may be caused by damage to one or more areas of the central and peripheral nervous system. They can be unilateral or bilateral, paresis or paralysis. Unilateral vocal fold paralysis can have mild to severe dysphonia with a breathy, low-intensity voice quality. Bilateral vocal fold paralysis can have serious medical concerns for the client as they do not have normal respiration. Spasmodic dysphonia is a relatively rare voice disorder. It may have either both neurological or psychological etiologies. The onset is insidious and is progressive over months or years. The voice quality is strained, strangled, and harsh. These clients do not respond well to voice therapy alone. They also need medical and surgical management.
Voice Evaluation and Therapy, Chapter 29. A team is needed to examine and evaluate the voice, such as a speech therapist and an otolaryngologist or an ENT. To do this, various methods are available, such as an indirect laryngoscopy and endoscopy. An indirect laryngoscopy examines the larynx and vocal folds by placing a laryngeal mirror into the back of the mouth. It reflects a light onto the mirror that shines onto the vocal folds and makes them visible. An endoscopy allows the ENT to view the velopharyngeal mechanism, vocal tract, or both using an endoscopy introduced through the nose or the mouth. It has a camera lens and a fiberoptic light that illuminates the nasopharynx, oropharynx, and larynx. It has the option to use a strobe mode, making the vocal folds to appear to move in a slower motion. Videotaping is also available. A voice screening in schools is evaluated by an SLP using a variety of tasks, like counting from 1 to 10, a conversational voice sample, and phonating various vowels for more than 5 seconds each. With this, the clinician is able to determine if rescreening should be done or if the child needs a complete voice evaluation. To complete a voice evaluation, the speech-language pathologist needs a case history, an interview of the client, and a rating scale. Previous to seeing an SLP, the client has seen an ENT doctor. The SLP needs to review the file prior to seeing the client. During the interview of the client describes the problem, the onset, and the contributions to the voice disorder. During the interview, the SLP is evaluating the speech, the quality of voice, the vocal abuse, such as throat clearing, coughing, and tension in the voice or the body of the client. Then the clinician uses a rating scale that evaluates 6 voice characteristics, such as roughness, described as the irregularity in the voice source, breathiness, the audible air escape in the voice, strain, the vocal effort, the pitch, and the loudness of the client. This is an example of a rating scale. The perceptual, acoustic, and physiological correlates are also evaluated. Instruments to evaluate the voice measures are aerodynamic assessment, the electroglottography, electromyographic, photoglottography, and others. These are images of an electroglottography and photoglottography. The last step to complete a voice evaluation is a self-perception scale. This evaluates the client's self-perception of the voice disorder in 3 areas: the emotional, functional, and physical aspects, assessing the effect the voice disorder has in a person's life. Various voice therapy approaches are available. However, the clinician needs to find and be knowledgeable of the various approaches and decide the best one for the client. Now we will look at a hygienic voice therapy, symptomatic, psychogenic, physiological, and holistic voice therapy. Hygienic voice therapy is often the first step. It focuses on instilling healthy vocal behaviors, helping the person become aware of the damaging behaviors such as frequently speaking loud, speaking or singing outside of the pitch range of a person, and making hard glottal attacks. Internal hydration is a key component of a hygienic voice therapy. The goal of symptomatic voice therapy is to identify through a diagnostic process the misuse or abuse of the respiratory, phonatory, or resonatory systems, inappropriate loudness, vocal pitch, and rate of speaking. When those are identified, the misuse or abuse are eliminated or reduced through auditory feedback, change of loudness, counseling, and relaxation. In a psychogenic voice therapy, the emotional and psychosocial behavioral reasons that cause a voice disorder are identified and modified. A physiological voice therapy focuses on directly modifying or altering the physiology of the vocal mechanism through exercise and manipulation of the respiratory and phonatory systems. Last is a holistic voice therapy. This is a combination of some or all of the approaches of voice therapy. We will now discuss the laryngectomy. For treating laryngeal cancer, in some cases, the larynx is surgically removed. A stoma is made. This is an opening that is about a diameter of a finger or a thumb. It allows air to enter and exit the lung. Speech-language pathologists have a big role before and after the surgery. Before the surgery, the SLP meets with the patient and family to discuss the client's communication means and the role that the SLP will have after. To communicate, various different methods are available, such as the Tracheoesophageal Puncture, the Esophageal Speech, and the artificial Larynx. Emotional and social effects of voice disorders. Chapter 30. For young children and parents. Parents and children at this age seem to be unaware or unconcerned about the problem. Parents are counseled about how to help their child reduce the abuse of their voice during talking or playing. The ENT and the parents have to work in unison to motivate the child to assist voice therapy. For adolescents, this is when concern begins to emerge. Developing an acute laryngitis is looked upon as an honor. They cheer their team on. It is when the loss of voice occurs that they might be willing to follow a voice therapy regimen. Adolescents with falsetto voice, particularly boys, may have serious emotional reactions to their voice disorder. They become isolated and parents become concerned about their son's feelings and relationships. For adults, having a voice disorder may affect their social success, career success, or both. The voice is often a mirror of a person's reactions to what is going on in that person's life. As clinicians, our understanding of the voice reflection of the person and of the human condition in general allows us to help many people regain their voices and then maintain them by better coping with life's changes.